You know that feeling when you're just, well, a bit off, maybe more tired than usual, or your stomach's acting up in that kind of vague way, or you've got those little niggling aches that don't really seem to go anywhere. Okay, let's sort of unpack this.
Yeah.
Because sometimes our bodies give us these subtle clues, right? And they could actually point to something quite specific happening beneath the surface. Maybe even something you wouldn't immediately suspect, like high calcium levels in your blood.
Exactly. And that's precisely what we're going to be digging into today, hypercalcemia.
Right.
Think of this as your, well, streamlined guide to understanding this condition. Our mission really is to give you the essential information clearly and concisely.
Yeah, perfect for revision.
Perfect if you're revising,
Yeah.
or even if you just want to get a solid handle on what it's all about. We'll cover what hypercalcemia is, what causes it, who might be at risk,
How it affects the body.
how it affects the body, how it's spotted, how it's treated, and those kind of key things to watch out for.
And just so you know, we've gone through some pretty detailed revision notes for this. We've tried to pull out the really crucial bits of knowledge.
Yeah, distilled the key stuff.
Exactly. So you don't have to wade through absolutely everything yourself. So let's start with the basics then. What exactly is hypercalcemia?
Okay, so simply put, hypercalcemia just means you have a higher than normal level of calcium in your blood.
Higher than normal.
Yeah. The usual upper limit is around 2.6 millimoles per liter, or you might see it as 10.5 milligrams per deciliter. Anything above that, basically, is considered hypercalcemia.
Okay.
Now remember, calcium itself is vital. It does loads of things, nerve signals, muscle contractions, including your heart, obviously.
Blood clotting.
Blood clotting, yeah, and keeping bones strong. So having the right amount is really crucial.
Right. So calcium's definitely a good guy in the right dose, but, too much of a good thing. What happens then? How does the body normally keep calcium in that sweet spot?
Well, our bodies have this really clever system for managing calcium levels. And a key hormone involved is parathyroid hormone, or PTH.
PTH, okay.
Think of PTH as like the body's calcium thermostat. When your blood calcium dips too low, PTH gets released. And it tells the body to do a few things. Release more calcium from the bones,
Right.
absorb more from your food in the intestines, and hang on to more in the kidneys. It brings the level back up.
So low calcium triggers PTH to sort of crank things up. Now, I've heard that sometimes when you get your blood calcium checked, the result might be adjusted. What's that about?
That's a really good point. When the lab measures your total calcium, it's measuring, well, two things. The calcium that's freely floating around and the calcium that's attached to proteins in your blood, mostly albumin.
Okay.
But it's only the free, unattached calcium that's biologically active, the stuff causing effects.
I see.
So if your albumin levels are low, maybe because of liver disease or malnutrition, the total calcium reading might look falsely low, even if the active free calcium is normal or high.
Right, so it could be misleading.
Exactly. So doctors often calculate an adjusted or corrected calcium level. It gives a better estimate of the active calcium by accounting for the albumin level. There's a standard formula they use for this.
Okay, that's helpful to know. So we know hypercalcemia is too much calcium. Now, what are the common reasons? Why might someone end up with high calcium levels? What are the usual suspects we should be thinking about, especially for revision?
Okay, so the causes, we can generally move them into two main buckets, really.
Right.
Those that are driven by too much parathyroid hormone, so PTH-mediated causes, and then those that happen for other reasons where the PTH level isn't necessarily high, non-PTH-mediated.
PTH-driven first, then. What are the big players in that group?
The most common cause here, by far, actually, is primary hyperparathyroidism.
Okay.
This is basically when one or more of your parathyroid glands, those tiny glands in your neck, become overactive. They just pump out too much PTH, even when calcium levels are already normal or high. It's like the sensor is faulty,
Yeah, the thermostat's broken.
Kind of, yeah. The other main PTH-mediated cause to be aware of is certain cancers. Specifically, breast, lung, and kidney cancer are common ones linked to this.
How do they cause it?
Well, sometimes these cancers can release substances that act a bit like PTH, effectively tricking the body into raising calcium levels.
Okay. And then the other category. The cause is not related to high PTH.
Right, the non-PTH-mediated ones. This is a, well, more mixed bag. Cancer itself can cause hypercalcaemia through several other mechanisms that don't involve mimicking PTH directly. We'll probably touch on those later.
Okay.
Then you've got granulomatous conditions, things like sarcoidosis and tuberculosis. These involve inflammation that can mess with calcium regulation.
Right, inflammation.
Certain endocrine disorders, too, like an overactive thyroid toxicosis or pheochromocytoma, which is a rare adrenal gland tumor, even adrenal insufficiency, so underactive adrenals.
It's interesting.
And definitely don't forget medications. Thiazide diuretics are a classic cause often used for blood pressure.
Ah, yes, thiazides.
And taking very high doses of vitamin D or even vitamin A supplements, these are key culprits to remember.
Thiazides and vitamins, got it. Anything else in that non-PTH list?
Yeah, a few others. There are some genetic conditions. Probably the most important one to know is familial hypercalcemia, or FHH.
FHH.
It's genetic.
Yeah.
The kidneys basically don't get rid of calcium properly, so blood levels go up. Interestingly, the calcium in the urine is low. That's a key difference.
Low urine calcium, okay.
Then less common things like being immobile for a long time, like prolonged bed rest. Your bones can actually start releasing calcium.
Really? Just from not moving?
Yeah, use it or lose it in a way.
Yeah.
Also calcium alkali syndrome that used to be called milk alkali syndrome from taking way too much calcium and alkali, like certain antacids. And it's occasionally seen in some people with AIDS, too.
Wow, okay. That is a comprehensive list. So for revision, maybe primary hyperparathyroidism and malignancy are the two big ones to focus on initially.
Absolutely. They are the most common causes in adults.
You mentioned cancer can raise calcium in a few different ways, not just mimicking PTH. Can we dive a bit deeper into those mechanisms? That sounds important.
Definitely. This is quite high yield for exams, too.
Yeah.
So cancer can lead to high calcium through, let's say, 4 main routes.
Okay.
One is the production of something called parathyroid hormone-related peptide, or PTHrP.
PTHrP.
Yeah. Think of it as a sort of molecular mimic of PTH. It latches onto the same receptors on bone and kidney cells.
Oh, okay.
And basically tells them to release calcium and hold on to calcium, just like PTH does. But the actual PTH level from the parathyroid glands might be low or normal.
Right, because the body thinks there's enough calcium.
Exactly. The second way is what we call osteolytic hypercalcaemia. This happens when cancer cells spread to the bone metastases and literally destroy the bone tissue.
Like breaking it down.
Precisely. And as the bone breaks down, calcium gets released straight into the bloodstream, like demolition-releasing dust.
Got it. What else?
Some cancers, particularly lymphomas, can actually produce too much of the active form of vitamin D, which is called calcitriol, or 1025-dihydroxyvitamin D.
Active vitamin D.
Yep. And that cranks up calcium absorption from your gut. And finally, though it's quite rare, some tumors can actually produce PTH itself, ectopic PTH production.
Wow. Okay, so cancer really has multiple tricks up its sleeve to raise calcium levels. Now, thinking about who's more likely to get this, what are the risk factors we should be aware of?
Yeah, good question. We can kind of group the risk factors.
Okay.
First, demographic factors. Hypercalcaemia tends to be more common as people get older.
Advanced age.
Right. And females seem to be slightly more prone to it than males, mainly because primary hyperparathyroidism is more common in women, especially after menopause.
Okay. And family history.
Yes, if you have a family history of hypercalcaemia itself, or specifically of hyperparathyroidism, your risk might be a bit higher.
So age, gender, family history. What about genetics, beyond that familial condition FHH you mentioned?
Yes, certain inherited genetic disorders definitely increase the risk. The main ones are the multiple endocrine neoplasia syndromes, often called MEN syndromes, MNN1 and MN2.
Men's syndromes?
These affect multiple hormone-producing glands, and they significantly raise the risk of developing primary hyperparathyroidism and therefore hypercalcaemia.
Okay. And then what about sort of lifestyle things or other health conditions?
Absolutely. Prolonged immobilization, like we mentioned, being stuck in bed for a long time, that increases bone breakdown.
Right.
Chronic kidney disease is another big one. It really messes with calcium and phosphate balance. And of course, as we've discussed quite a bit, having a history of certain malignancies is a major risk factor.
Makes sense. And finally, medications. We mentioned thiazides and high-dose vitamins A and D. Any others to keep in mind?
Well, those are the main ones. There's maybe some weaker evidence linking long-term use of proton pump inhibitors, PPIs.
Oh, for reflux.
Yeah, exactly. Things like omeprazole. Some studies suggest a possible link to slightly increased risk, but it's not as clear-cut as with thiazides.
Okay, good to know. So it feels like there are quite a few different paths leading to hypercalcemia and various risk factors. Let's think about what's actually going on inside the body when calcium levels creep up. What's the pathophysiology?
Right, so the underlying mechanism, the how it works, really depends on why the calcium is high. It depends on the cause.
Okay, well, let's start with primary hyperparathyroidism again, since you said that's common. How does that work?
Sure. So in primary hyperparathyroidism, you've got one or more overactive parathyroid glands just churning out too much PTH.
Right.
This excess PTH then does three main things. One, it increases bone resorption, that's the breakdown of bone, which releases calcium and phosphate into the blood.
Okay, break down bone.
Two, it tells the kidneys to reabsorb more calcium, so less gets peed out.
Mhm.
But interestingly, it tells the kidneys to get rid of more phosphate.
Ah, okay, less calcium, more phosphate in the urine?
Generally, yes. And three, PTH boosts the activation of vitamin D in the kidneys, which then increases calcium absorption from the gut.
So it hits bone, kidneys, and gut.
Exactly. All roads lead to higher blood calcium. You can sometimes hear that mnemonic bones, stones, abdominal groans, and psychiatric overtones for hyperparathyroidism symptoms, which hints at these effects.
Right, bones, stones, groans. Yeah, I've heard that. What about when cancer is the cause? Is the pathophysiology similar?
Well, the end result is high calcium, but the triggers are different, as we discussed with those mechanisms like PTHrP production,
Right, the mimic hormone.
or direct bone destruction by metastases, or the tumor making active vitamin D. So you still get increased calcium release from bone, or increased absorption, or maybe reduced kidney excretion, depending on the mechanism, but it's driven by the cancer, not primarily by the parathyroid glands.
Got it. Different starting points, same problematic result. And what about all those other causes like sarcoidosis or thiazides? How do they fit in?
Again, different mechanisms. In granulomatous diseases like sarcoidosis, the inflammatory cells themselves can actually start producing active vitamin D, bypassing the normal kidney control.
Wow, the inflammation makes vitamin D.
Sort of, yeah. It leads to increased calcium absorption. Thiazide diuretics, on the other hand, work mainly by reducing how much calcium the kidneys excrete. They make you hold on to more calcium.
I see.
Impaired kidney function, well, that's complex, but fundamentally the kidneys can't get rid of the excess calcium efficiently. So you see, it's all about disrupting that normal balance. Too much
Mhm.
coming in or not enough going out.
Okay, that makes sense. So if someone presents with high calcium, there's clearly a list of possible culprits. How do doctors sort through that? What's the differential diagnosis process like?
It's really about putting the clues together. When you see hypercalcemia confirmed on a blood test, the first thing you usually check is the PTH level.
Right, the PTH test.
That's the major branch point. Is the PTH high or inappropriately normal? If, yes, you're thinking primary hyperparathyroidism is most likely, or maybe that rare FHH.
Okay.
If the PTH is low or suppressed, then you know the parathyroid glands are responding correctly to the high calcium, and the cause lies elsewhere.
So you look at the non-PTH list.
Exactly. That's when you start thinking strongly about malignancy, vitamin D toxicity, those granulomatous diseases, medications like thiazides, maybe thyrotoxicosis, immobilization. You work through that list based on the patient's history, other symptoms, and further tests.
So key differentials to keep in mind for revision would be primary hyperparathyroidism, malignancy, maybe vitamin D excess, thiazides, and FHH.
Those are definitely the top ones to consider, yes.
Okay. It sounds like a bit of detective work involved. Now, how common is this actually? What does the epidemiology look like, say, here in the UK?
Well, primary hyperparathyroidism is actually relatively common.
Yeah.
Figures suggest it affects maybe around 1% of the general population.
1%. Okay.
Malignancy-associated hypercalcemia is less common overall in the population, maybe around 15 new cases per 100,000 people per year.
Not.
But it's much more common in people who already have cancer, especially advanced cancer. For them, it's a frequent complication. So the numbers depend a lot on who you're looking at.
Right, makes sense. Are there any specific groups who are more likely to be affected by, say, hyperparathyroidism?
Yes, definitely.
Yeah.
Primary hyperparathyroidism is significantly more common in women, especially after menopause,
Postmenopausal women.
and in older individuals generally. The prevalence estimates range from about 1 up to maybe 7 cases per 1,000 adults, increasing with age.
And the malignancy-related type.
As you'd expect, that's seen most often in people with advanced cancers. Breast cancer, lung cancer, and renal cell carcinoma are particularly common culprits for causing hypercalcemia. It's less common in children, although we don't have great UK-specific incidence data for kids.
Okay, so older adults, post-menopausal women for hyperparathyroidism, and advanced cancer patients for the malignancy type. Now, let's talk about how this actually shows up. What are the typical signs and symptoms someone might experience?
Well, the tricky thing here is that the symptoms can be really variable and often quite nonspecific, especially when the calcium is only mildly elevated.
Non-specific meaning could be lots of things.
Exactly. Fatigue, weakness, things that many conditions can cause.
Right.
But some of the more characteristic things, if you put them together, include constipation, needing to urinate more often, that's polyuria, and feeling really thirsty, polydipsia.
Constipation, peeing more thirsty. Okay.
People might also get muscle aches or bone pain. Cognitive changes are common. To difficulty concentrating, maybe feeling a bit low or depressed. Confusion in more severe cases.
And stomach issues.
Yes, gastrointestinal symptoms like nausea, maybe vomiting, loss of appetite, and general abdominal pain or discomfort are pretty common. Remember that mnemonic again. Stones, bones, groans, thrones, and psychiatric overtones.
Stones, bones, groans, thrones, psychiatric overtones. Yeah, that covers a lot.
It does. Stones for kidney stones, bones for bone pain, groans for abdominal pain, constipation, nausea, thrones for the polyuria, and overtones for the cognitive or mood changes. It's a useful checklist.
That's a great one for revision. What happens if the hypercalcemia gets really severe?
Yeah, if the calcium level climbs quite high, you can get more serious complications. Dehydration can become a big problem because of the polyuria. Kidney stones are more likely.
Okay.
You can see quite marked changes in mental status, serious confusion, lethargy, drowsiness, even progressing to coma in extreme cases, and potentially dangerous heart rhythm problems, cardiac arrhythmias.
That sounds serious.
It can be, yeah. There are also some specific signs a doctor might look for on examination. Sometimes you can see calcium deposits in the cornea of the eye, called band keratopathy. An ECG might show a shortened QT interval. And hypertension, high blood pressure, can also be associated with it.
And does the severity of symptoms always match the calcium level?
Generally, higher levels mean more severe symptoms, but not always. Some people tolerate quite high levels surprisingly well, while others feel symptoms even with mild elevations. And importantly, some people, especially with mild chronic hypercalcemia, like from primary hyperparathyroidism, might have no noticeable symptoms at all.
So it could be found just by chance on a blood test.
Absolutely.
Yeah.
It's often picked up incidentally during routine blood work for something else entirely.
You mentioned different levels and symptoms in our notes. Could you quickly recap that sort of ranges?
Sure. Roughly speaking, if the calcium is just mildly up, say below 2.8 millimolar, you might see that increased urination and thirst, maybe some indigestion, perhaps mild depression or cognitive fuzziness.
Okay, subtle stuff.
As it gets a bit higher, maybe up to 3.5 millimole, you're more likely to see muscle weakness, definite constipation, maybe loss of appetite, nausea, and noticeable fatigue.
Getting more obvious.
Yeah. And then when it climbs above 3.5 millimole, that's when we often see the more severe end. Significant abdominal pain, vomiting leading to dehydration, marked lethargy, confusion, and the risk of those cardiac arrhythmias and ECG changes becomes much higher. Coma is possible at very high levels.
Right, okay. That's a useful guide. What about long term? If hypercalcemia isn't treated, what happens over years?
Well, over time, persistently high calcium can cause damage. Calcium can start depositing in soft tissues where it shouldn't be: blood vessels, kidneys, joints.
Okay.
We mentioned kidney stones nephrolithiasis. You can also get calcium deposits within the kidney tissue itself, called nephrocalcinosis, which can impair kidney function.
Ah, so stones and deposits in the kidneys.
Yes. And in joints, you can get calcification of cartilage, called chondrocalcinosis, which can cause joint pain. Plus the effects on bone we talked about, leading potentially to osteoporosis.
So definitely something you want to catch and manage. How do doctors investigate it once it's suspected? You mentioned the PTH test is key.
Right, so step 1 is confirm the high calcium, ideally with an adjusted calcium level. Step 2 is usually checking PTH.
Okay, what else?
Along with PTH, you'll want to check phosphate levels. Remember, in primary hyperparathyroidism, phosphate is often low or low normal. You'll check kidney function, urea, and electrolytes. Alkaline phosphatase can give clues about bone turnover.
Alkaline phosphatase, right.
Measuring vitamin D levels, specifically 25-hydroxy vitamin D, is important too to rule out vitamin D toxicity or deficiency. And depending on the suspected cause, other tests might be needed. Maybe tests for myeloma or thyroid function tests.
So a panel of blood tests usually. What about imaging?
Imaging comes in to help pinpoint the cause, especially if surgery is being considered. or to look for complications. If primary hyperparathyroidism is suspected based on high calcium and high normal PTH,
Yes.
then imaging of the neck is often done to try and locate the overactive parathyroid gland or glands before surgery. Ultrasound is often the first step.
Neck ultrasound.
And sometimes a nuclear medicine scan called a sestamibi scan, or occasionally a specialized CT scan.
Okay. And for other causes?
If you're worried about kidney stones or nephrocalcinosis, a CT scan of the abdomen and pelvis is good. Bone x-rays might be done if bone pain is prominent, or if you suspect bone metastases from cancer, looking for those lytic lesions or fractures. But x-rays aren't super sensitive for early changes.
Right. And sometimes more specialized tests.
Occasionally, yes. If a granulomatous disease like sarcoidosis is suspected, you might need chest imaging or even a biopsy. And if FHH is on the cards, genetic testing is the definitive way to diagnose that.
Okay. There were some typical lab findings summarized in the notes for different causes. Could you maybe highlight a couple of key patterns, like primary hyperparathyroidism versus malignancy?
Sure. Okay, so classic primary hyperparathyroidism.
Yeah.
You expect high calcium, high or inappropriately normal PTH, often lowish phosphate, and maybe high alkaline phosphatase if there's bone involvement. Urine calcium is typically high.
High calcium, high PTH, low phosphate. Got it. What about malignancy?
Malignancy is more variable, but typically if it's causing hypercalcaemia, the PTH level will be low or suppressed.
Low PTH. That's the key differentiator.
Often, yes, because the high calcium is coming from the cancer via PTHrP or bone destruction, not from the parathyroid, so the parathyroid shut down. Phosphate can be variable. Alkaline phosphatase might be very high if there are bone mets. Urine calcium is usually high too.
Okay. And vitamin D excess.
Vitamin D excess. You'd expect high calcium, a suppressed PTH because the parathyroid shut down, often high phosphate, and obviously high levels of vitamin D metabolites if you measure them.
Right. And FHH, you mentioned low urine calcium.
Exactly. FHH looks a bit like mild primary hyperparathyroidism, high calcium, high or normal PTH.
Right.
But the key difference is low urine calcium excretion. That's the hallmark.
Low urine calcium and FHH. Okay, that's super helpful for differentiating. So once you've done the investigations and figured out the likely cause, what's the plan? How is hypercalcemia managed?
Like everything else we've said, it really depends on the underlying cause and also how severe the hypercalcemia is. How high is the calcium and how sick is the patient?
Okay, let's start with milder cases, maybe asymptomatic ones found by chance.
Right. In those cases, the main focus is addressing the underlying cause, if possible and appropriate.
Yeah.
If it's mild primary hyperparathyroidism without complications, sometimes watchful waiting with regular monitoring is an option, especially in older individuals.
Watchful waiting.
Yeah, monitoring calcium levels, kidney function, bone density.
Mm.
But often, particularly in younger or symptomatic patients, surgery to remove the faulty parathyroid gland, a parathyroidectomy, is recommended as its curative.
Okay.
If it's due to a medication like a thiazide, stopping the drug is usually the first step. If it's mild vitamin D excess, adjusting supplements, you treat the root cause.
Makes sense. Now, what about severe cases? When the calcium is really high or the person is clearly unwell?
Severe hypercalcemia, especially if symptomatic, is a medical emergency and needs immediate treatment to lower the calcium levels quickly.
Emergency. Okay, what do you do first?
Fluids, fluids, fluids.
Mm-hmm.
Intravenous saline hydration is the cornerstone. It helps dilute the calcium and, more importantly, rehydrates the patient and improves kidney function, allowing the kidneys to excrete more calcium.
IV fluids. Got it. What else?
Once the patient is well hydrated, we often use intravenous bisphosphonates, drugs like pinidronate or zoledronic acid. These are very effective at inhibiting bone resorption. They basically stop the bones releasing so much calcium.
Bisphosphonates to stop bone breakdown.
Exactly. They take a day or two to fully kick in, though.
Yeah.
For a more rapid, although often temporary effect, we might use salmon calcitonin.
Calcitonin.
Yeah, it works quickly to lower calcium, but its effect tends to wear off after a couple of days. Loop diuretics, like furosemide, might be considered if the patient is fluid overloaded, but they aren't a primary treatment for lowering calcium itself and shouldn't be given if the patient is dehydrated.
Right. Careful with diuretics.
In certain situations, like hypercalcaemia due to sarcoidosis or some lymphomas or vitamin D toxicity, glucocorticoids, steroids, can be very effective.
Steroids for specific causes.
Yes. And there are other options for refractory cases or specific scenarios, things like cinacalcet for hyperparathyroidism if surgery isn't possible, denosumab as another option for a malignancy-related hypercalcaemia resistant to bisphosphonates, And in really severe life-threatening cases, especially with kidney failure, hemodialysis can physically remove calcium from the blood.
Dialysis as a last resort. Wow, quite an arsenal of treatments. What about managing things long term?
Long term, it always comes back to treating that underlying cause. Regular monitoring is key, checking calcium, kidney function, bone density as appropriate. The goal is to keep calcium levels stable and prevent those long-term complications we talked about.
Okay.
It often requires collaboration between different specialists like endocrinologists, oncologists, nephrologists, depending on the cause.
You had a few extra notes on managing PTH-mediated hypercalcemia specifically. Anything else to add there?
Just to reiterate that for primary hyperparathyroidism, even if asymptomatic, surgery is often considered, especially if there's evidence of kidney impairment, significant hypercalciuria, high urine calcium, osteoporosis, or if the serum calcium is quite high, like 0.25 millimole above the upper limit.
So surgery is often the preferred route if possible.
For definitive treatment, yes. If surgery isn't done or while waiting, patients should be advised to stay well hydrated, stay mobile, and avoid very high calcium diets or medications that can raise calcium like thiazides.
Good practical advice. So tying it all together, what's the general outlook? What's the prognosis for someone diagnosed with hypercalcemia?
And it really hinges on the underlying cause. For primary hyperparathyroidism, if treated surgically, the prognosis is generally excellent. The cure rate with surgery is very high.
That's good news.
For hypercalcemia related to malignancy, sadly, the prognosis is often poorer, as it usually indicates advanced cancer. The outlook depends more on the cancer itself and its response to treatment, but managing the hypercalcemia can still significantly improve quality of life. For other causes, the prognosis depends on how well the underlying condition can be controlled.
So variable, but treating the cause is key.
Absolutely. And a regular follow-up is essential to monitor for recurrence or complications.
Speaking of complications, let's just quickly recap the main ones again. What are the potential long-term problems if hypercalcemia isn't managed well?
Sure. We've got kidney stones, kidney damage potentially leading to chronic kidney disease or even failure, weakened bones leading to osteoporosis and increased fracture risk, cardiovascular issues like hypertension and arrhythmias, gastrointestinal problems like peptic ulcers or even pancreatitis have been linked, and those cognitive issues which can sometimes be persistent.
And severe hypercalcemia itself can be life-threatening.
Yes, hypercalcemic crisis is a medical emergency. So prompt diagnosis and effective management are crucial not just for long-term health, but sometimes for immediate survival. Managing it effectively can be challenging, especially in advanced malignancy, but addressing the underlying cause gives the best chance of minimizing these complications.
Okay, so hypercalcemia, definitely more complex than just a high calcium number on a test. Really understanding the why behind it seems absolutely critical for getting the management right and preventing those complications down the line.
Couldn't agree more. It really highlights how interconnected everything is in the body and how a disruption in something like calcium balance can have such wide-ranging effects.
Yeah, absolutely. And maybe here's a final thought for you to mull over. Think about how those seemingly unrelated symptoms we mentioned at the start, that fatigue, the vague aches, maybe the constipation, how they could sometimes be the body's way of signaling an underlying metabolic issue like hypercalcemia. It's a good reminder, isn't it, of how important it is to listen to your body and maybe think a bit broader sometimes.
That's a great point. And if this deep dive has been useful for you, perhaps for your MSRA revision or just generally, do check out the resources available on pastthemsra.com.
And freemsra.com as well for more helpful content.